Good morning, everyone. It is 10 o'clock and time for our every second week of the month coronavirus update. We are going to talk today about COVID-19 in the post-COVID clinic, studying the long-term effect of COVID-19 with our guest speaker, Dr. Aruni Bhatnagar. But before we do that, I am going to act today as a primary care physician and giving you the COVID-19 update. Oh yeah, and I forgot. I'm so sorry, Justin. I want everyone, if you do not mind, to put the name of the county from which you come from into the chat, so that we can just see what our reach is. And I am apologizing for the fact that we have no primary care physician here or MD to give us the update, but we are a little bit busy. We have Dr. Furman is on hospital duty this week, and Dr. Laura Morton is working with us on a COVID-19 nursing home project ECHO, where we are training and educating nursing home staff on how to manage the disease. So we are a little bit busy today, so we are multitasking. So thanks everyone for being here today. I'm just going to give you a little bit of statistics that you probably, most of you know, but I want to re-emphasize this data. First of all, nationwide, we have over 10 million cases of COVID-19 right now and 238,251 deaths. In Kentucky alone, 85 or 71% of the counties in Kentucky are in a red zone, with more than 25 daily cases per 100,000. We have a total of 122,567 cases currently in Kentucky, of which we have 1,576 deaths, and the positivity rate has gone up to 7.49. So many schools are starting to close in our area. Those who have opened are starting to close. We just heard that Oldham County is closing on Friday. So there's just a lot of stuff happening right now. I now want to just quickly tell you too that the long-term care facilities in Kentucky is also struggling. We have a total of 7,103 cases of nursing home individuals who are affected by COVID, 955, almost 1,000 of deaths. Total staff cases is 5,024, with total staff deaths 6. Now, if you look at the universities and colleges, you've got 5,773 student cases in the state of Kentucky and 107 staff cases and no deaths. So you can see how more vulnerable our older adults are in the long-term care facilities. Schools, we have 3,585 student cases and 1,649 staff cases, of which 2 staff died. So that's the stats. The mask mandate is still in effect. We do hope that the governor will start looking at what the next step need to be to keep us safe in Kentucky. But that is, for the most part, an update of where we are in the state of Kentucky, and it doesn't look too good. So with that, I am going to introduce you to our speaker, Dr. Aruni Bhatnagar, Ph.D. and the director of the Christina Lee Brown Envirome Institute. Dr. Bhatnagar is professor of medicine and a distinguished university scholar at the University of Louisville. He is the director of the Christina Lee Brown Envirome Institute and co-director of the American Heart Association Tobacco Regulation Center. He is a leading expert on the mechanisms by which environmental exposures, such as air pollution, affect cardiovascular disease risk. Dr. Bhatnagar's initial work involved the purification and characterization of aldose reductase and his role in diabetic complications. To this end, he established the identity of this enzyme in several tissues and investigated its structural, kinetic, and inhibitory properties. His work has shown that increasing no availability prevents aldose reductase activation and sorbitol accumulation in diabetic tissues. He has participated in over 50 NIH review panels and chaired several review panels. He was a recipient of the President's Award for Outstanding Scholarship, Research, and Creative Activity, University of Louisville, and Partner in Healthcare Award, contributing to greater Louisville healthcare community in 2007. In 2007, he also received the first Outstanding Faculty Mentor of Graduate Studies and the Outstanding Mentor Award for the Conference of Southern Graduate Schools. In 2017, he was designated research exemplar by the Washington University. Dr. Bhatnagar has published 370 peer-reviewed manuscripts, 25 book chapters and reviews, and over 200 abstracts. He has mentored 48 graduate students and postdoctoral fellows in his laboratory and has served on the dissertation committee of 18 PhD students. So with that, thank you, Dr. Bhatnagar, and we are really looking forward to hear from you about the post-COVID clinic that is starting to, it's in its forming phases. This clinic is designed for follow-up care for any subsequent long-term health issues that may arise due to COVID-19 infection. And Dr. Bhatnagar will explore what the post-COVID clinic hopes to accomplish, including creating a registry of all confirmed COVID patients, specifically in Jefferson County. So with that, I hand it over to you. Thank you for being here with us.
Well, thank you very much, Anna, for that kind and long introduction. I have been sort of, it seems like I've been busy, but there have been sort of lots of people involved in accomplishing all those things. I just wanted to share my screen if it's possible. I'll show you some slides, and then that would be sort of a good template for discussion. Let me try if I can do that.
Dr. Bhatnagar, you should be able to share now.
Yes, I can. Okay, can you see my screen? Okay, great, and you can see the full screen, right? Okay, so I'm going to, like Anna said, I'm going to talk a little bit about the post-COVID clinic that we are thinking of establishing, which I think is already in its way, but also to sort of give a little bit of a prelude to that and how we got there. And so I wanted to discuss our work, a project that we sort of launched because there was great need at the beginning of the pandemic, and so will tell us how we got to the formation of the clinic. So this project is what we call the Co-Immunity Project, and this actually started as a sort of a combined partnership with the major area hospitals in order to see what we can do together and to be able to understand the spread of the disease in our community. And this was very early in the stage of the spread of the pandemic, and so we had really no resources, no way of knowing what to do. We didn't have PPE, we didn't have kits, so we wanted to put our resources together and have a combined sort of a path forward. And so with the University of Louisville, as well as all the other area hospitals, we started with this Co-Immunity Project. And of course, the first aim of the project was to test the healthcare workers, but we thought that we could actually develop this project into multiple phases. First, because there's great need, and there is because the healthcare workers are most vulnerable, we thought we'll test healthcare workers. Then we thought after that we will test the community, do a randomized sampling of Jefferson County, and then do some in-person exams of people who are exposed so we can bring them back to our labs and then test them for the immunity, for their sort of long-term symptoms. And then we might even consider doing some analysis in rural Kentucky. And then finally, in the end, we sort of create a long-standing COVID survivors clinic. So it was a very sort of extensive, ambitious plan. And I must say that we have been able to at least get to phase 3 and even part of phase 5. So first of all, we wanted to test the healthcare workers. Like I said, that's important. It's been done in other places. People have shown that there are, that their healthcare workers have started being infected from the very beginning of the pandemic, and therefore there have been lots of infections both in the non-frontline and the frontline healthcare workers. There have been sort of reports from Wuhan and from Essen in Germany, where they think that there was, initially in Wuhan, there were a lot of deaths because the healthcare workers were not aware of the infectivity and the sort of lethality of this infection, and so were not as careful, and many of them were infected in the working environment. Where in Essen, there was a sort of a less infection and really not many deaths, because by the time they did the study, the people had become more careful. However, the largest study that was published sort of a few months ago was having, I think, a total of about 2 million community individuals and 99,000 healthcare workers. And this study was done in UK and US, and this was on a sort of a cell phone based study in trying to identify where the cases were. And they could, the healthcare workers had a hazard ratio of 11.6, which means they were 11 times more likely than the general population to be able to be infected. And so this shows that there was a very high hazard of people with the healthcare workers. So then what happened was that there was, but this was also a very large study, but also the beginning of the pandemic. And so we thought that we needed to do our own study. And in our study, we recruited in the first wave about 1,300 people, and we've done the repeated again with 1,000 people. And we found very low levels of infections. We were like 2 people out of 1,300. And this was in April. And in July, there were 4 people out of 1,000. Although a lot of people were positive to the antibody. There were about 14 here and 20 here. So we think that there was a lot of infection within the healthcare community, but it was not as much as been seen in other places. Maybe our healthcare workers were much more vigilant and careful, and so therefore they might have been sort of better prepared and so on. So therefore less rates of infection there. So then we started what we call as Co-Immunity 2, which is a randomized sort of study in which we wanted to look at what is the extent of the infection in the entire community. And you just had Anna sort of tell us what the infectivity rates are. Unfortunately, we do not know what those rates actually mean in the community. So if there are high-risk people, or people, if you create sort of a general panic, then more people who are positive come forth, even with mild symptoms, get tested, and so you get a very high positivity rate. Doesn't really mean that that's the positivity rate in the community, because unless you have a really random sample, you cannot tell what the rate may be. So for that, we did was we wanted to get a sample that is uniform sample from the Jefferson County. We know that there are different areas in the city. We are actually 4 or 5 different cities. So we have 4 different parts of the city, and they have different socio-demographic mix. And we said, now we want people from each part of this area that is representative of that area. So for example, if you are from area 1, which has this number of sort of whites, this number of blacks, then you have proportion number of whites and blacks from that area. So you have to have sort of proportion of this place. You have to have proportion of the race, you have a proportion of the age, and you have to have proportion of the sex, so that you would be able to get a uniform sample. And then you have to weight each one of those possible individuals. And but it's very, very difficult thing to do, because you have to invite all these people, and many people don't show up. So how do you ensure that your sample is adequate? So in the first experiment, first sort of wave of this in June, we invited about 18,000 people, only 500 responded out of these. And so, which is like, we send them letters out, and then these people registered themselves, and it was a drive-in testing that we did at 4 different locations in the city. Even then, very few people showed up. So we had other volunteers, just whoever wanted to get tested came forth. And then, so we found, but then the people who came up from the volunteer testing also were from different parts of the town. So we could weigh each participant accordingly, and we found that maybe the viral infection rates were about 0.05%, and the antibody rate was 4%. So which would suggest that the estimated sort of rate was about 20,000 people had gotten infected by June. At that time, I think the county had only reported 4,000. So you can see the extent of the difference, that how off we might be if we are just looking at convenience sampling and not random sampling. So then what we did was we tried to figure out at which places, what the extent of the fatality was. Because once you have a true, or not so true, but more reliable estimate of the rate of infection, you can calculate the fatality infection ratio, which was 1.3%. So we think that 1.3% of people who get infected succumb to the disease. We also found differences between whites and non-whites, and found that the non-whites were twice as susceptible to die from COVID infections as whites. We also found that there was a sort of a disparate distribution of incidence around the county, with more areas areas around the west part of Louisville had a much higher incidence of the disease, with higher prevalence at the time than at other areas. So this sort of uncovers the disparities and inequities in the rates of infection, but also in the rates of outcome. So then we repeated the whole thing again, and this was in September, and we invited 32,000 people this time. We sent 32,000 invitations to random addresses around the city, and we had about 1,500 people responded. We got another set of 630 volunteers. We tested 2,000 people, and they're from all over the town. We did a lot of sort of campaigning for people to come and join the project, come and get tested, and it was very laborious. We even went door to door, handing out flyers for asking people to participate. And what we found was, if we do the serology, that again, instead of like 4%, we now had 4.4% people who were testing positive, and that would mean that there would be 34,000 people who were infected at that time. The city had reported 17,000 people by that time. So again, there is a wide disparity. We had in the active infection, we have about 0.2% infectivity rate, which means that we have about 1,500 people infected in the whole county. And that week, the city had reported about 700. So we have again, if by randomization, we could get a much better estimate of the infectivity rate. I must say that we are doing this again as we speak. I think we're doing 3 days. We've already done 3 days, and we are going to do that for 4 additional days. Again, if anybody wants to register and get tested, we have opened the study to volunteers who just participate voluntarily. Last time when we did maybe 2,000 people, we found 4 or 5 positive. This time we have done maybe 400 people, and we've already found 14 or 15 positive cases. So there has been a tremendous rise of cases in November compared to the sampling that we did in September. We're still continuing that, and we know what the true infectivity rate was. And then if we do this again, and at this time we are looking at the mortality rates that within a county, and this has been sort of really low. Now it's about 0.09% of mortality. Many of the participants we talked about did not even have, I mean, they had symptoms, but did not notice them. And only when we told them that they had an antibody positive, that they thought, well, maybe we did have something sometime. We did the same thing with the convenience sample. Again, it's kind of similar sort of results. We had, much more cases than were reported officially, both for the serology and for PCR. We had for the PCR, we estimate there may be 5,000 people infected, where the Jefferson County only reported like 700. So anyway, so in addition to that, we thought we also wanted to sort of keep track of the community by understanding what's happening to the rates of infection by looking at the wastewater. Now, this is sort of a new way of looking at infections. We have been actually studying wastewater in terms of analyzing community-wide opioid use and tobacco use and exposure to air pollutants. And so this is pre-COVID. And so we sort of geared up to do the post-COVID analysis, and we started sampling the wastewater in Jefferson County. This sort of approach is beyond individual testing, and it can identify both symptomatic and asymptomatic individuals, which, you know, it's very hard to do that unless you do randomized sampling, just like we did. But that's very expensive, and this is a lot cheaper than that. It requires less effort, and the results are sort of a summation of the community exposure. The idea here is that we collect the wastewater and we collect the samples and we analyze the samples in the lab that is in the wastewater. So knowing how many, what the volume of the water is, how much the population is, that we might get some idea of where and how much the infection may be. It is still not a sort of a perfected approach, but we are working on it along with several other people around the country. Almost every city is trying to do this now. The initial sort of encouraging studies came from New Haven, Connecticut, where investigators from Yale showed that the increase in the virus in the sewage preceded the new COVID cases in that area, so that we could, you know, have at least a lead time in knowing whether there would be an increase in the incidence of this infection in the community. We sort of looked at different sewer sheds in the city, and we have again divided the city into 8 different zones, which kind of sort of coincide with the 8 zones that we were doing for random sampling. We sample about twice a week at 20 different sites, and we've been doing this for now 4 or 5 months. There is a, you know, because the methodology is not very standardized, we are still trying to figure out what it actually means, is what number of people are infected, then how would we go back to, so if we measure X amount of the virus in the sewage, how do we relate it to the prevalence of the virus in the community, or the number of cases. But the great advantage is that it can give us temporal and spatial resolution. We are following different sort of in the neighborhoods temporally, and it doesn't cost as much because we're only doing, say, 20 samples rather than, you know, trying to analyze 2,000 PCRs a week. And then it's kind of, in some instances, it could be stable. But we think that we have, and this will give us an additional assessment of the community-wide spread of the virus. In fact, in the last few months, we have been tracking, and the rates have been going up and down more or less in the noise level, slightly higher, sometimes slightly lower. But in the rates seem to have sort of exploded in the last 2 weeks. This is data from actually October, again, showing kind of what we have seen with randomized sampling. The highest rates are in Western Louisville and surrounded by some parts in South Louisville. The east part of the county in Jefferson County is relatively lower concentration of the virus. So it sort of reassures us that the type of data we've been getting from the community sampling may be reasonable, and that we could maybe follow this wastewater for monitoring for a while to see and to keep a better tab on where the infection is and whether it's spreading or not. So finally, I want to talk a little bit about Community 3, which is to do a clinical and immunological evaluation of people who actually have COVID infections. And so in this one, we plan to bring the people back to our labs who have actually been tested positive for the virus, which means that they've been infected to the virus. And here all those people that have had the infection, we have maybe identified 200 people. The great advantage that we have over other ways of sort of monitoring this disease or studying the diseases, that we have identified people who did not even have symptoms. So if we just recruited individuals who were positive, who went to the clinic, who had symptoms, that's what everybody else in the country are doing. And so we are doing that as well. We have addresses of all the 7, 8, 10,000 people who've been infected by the virus from the city, and we can then invite each one of them to come to to join our study. But I think that we want to look at some of the individuals who did not have any symptoms and individuals that had symptoms to see what's the progression of disease they have, what are the clinical features of their background is what environmental factors they are in. Maybe there are certain environmental factors that act additively or synergistically in determining the outcome of an infection and how severe it is, or whether there are any symptoms at all. We also want to look at the immune responses, why some people have high, why some people have low immune response, their susceptibility. We want to look at the IgG, IgM, and IgE levels. We also want to look at T cell immunity, and we want to look at cardiovascular and metabolic health, as well as in collaboration with Anna and her group, the social determinants of health, so that we would be able to get a complete assessment of what the type of environment these people are in, which sort of predisposes to a more severe outcome or prevents a more severe outcome. So finally, about the COVID clinic, I think that if we are going to be identifying these cases, and we have, then it is imperative that we offer some sort of a solution to the problem that we have identified. Many of the people that we work with have do not have PCPs, do not have any place to go, do not know what to do, and they share panic. And so we need to provide some sort of a place where they can come for immediate attention, but also for long-term care. Because we know that COVID is not something that just affects the lungs, it affects multiple organs in infected individuals. There could be neurologic changes, headache, dizziness, and stuff, which have been reported in some group of patients. There are also renal complications, at least acute kidney injury. There have been sort of hepatic and GI symptoms. Actually, some people only report GI symptoms and don't even report pulmonary symptoms on COVID infection. And they have just nausea, vomiting, and then they have sort of extreme lethargy and dizziness for many days. And then they recover. They don't have, these typical coughing and pneumonia-like features. There was one surprising study which actually reported that 70% of COVID patients have cardiac complications and cardiovascular inflammation. And so these are really serious, horrendous complications, and they, of course, vary in severity in people. But we have not even identified most of them. We have no way of actually having systematically understanding the extent of these complications. No one, as far as I know, in our community has followed this in our group of patients, and what type of symptoms are and what are the frequency of each of these symptoms is. And we have had no sort of indication of long-term sort of care for these people who might have lingering symptoms. We don't know. I mean, no, this is a new disease. We don't know if these are going to be just sort of transient changes, and then people will bounce back and they will be, as good as new, or they're going to have lingering health issues that would require frequent medical attention. So these are some of the sort of stats I was talking about. 87% people report fatigue. 78% have cardiac dysfunction. Actually, there was a study also showing that there is inflammation in the heart, so like a kind of myocarditis type of syndrome. There are people who report neurological symptoms, and even young adults have lingering health issues. In fact, I saw a study in the CT scan of young individuals who recovered from COVID without serious symptoms, had subclinical pulmonary damage, and even like ground glass opacities and fibrosis in the lung, even though did not have very severe symptoms, and they did not feel any different after the infection. So that's really cause for concern, and I think it behooves us to be able to provide sort of this service to our community, where we would be able to tell what these long-term complications are and how to deal with them. There are lots of questions regarding that, about what are the long-term changes in the function of the lung, what is the changes in myocardial function, what happens to myocardial injury, and do these people, especially like in the 50s and 60s, once they recover from COVID, have a greater susceptibility for a myocardial infarction, for instance, right? Whether these people would have greater vulnerability to cardiac arrhythmias. And so we need to know all these things because that we would be prepared if a range of cases appear in our community in the future, not just treating them sporadically. Many places can do that, Norton and Baptist, but if you go there, they can provide care. But we want to have a repository of knowledge within the university, given that we are primarily an academic institution. And we could begin that by actually creating a registry of the people who had COVID within the city and maybe even within the state, and inviting everybody to come to our clinic to have a checkup to see what the baseline status is, what's their neurological function, what's their cognitive function, cardiovascular function, renal function. And so if we have this baseline information that something happens to them or how they progress, even if they get better, that's great to know. So we want to follow that. So the big question then is how to manage these long-term complications. Like I said, first we started with creating a statewide registry. We have frequent follow-ups. I've been talking to people at the NIH, and they have other universities trying to do the same thing. They're trying to create a network of post-COVID care clinics where we could develop a standardized protocol of how to evaluate sort of respiratory, cardiovascular, renal function, and so on. What sort of battery of tests should be done to be able to know what the health of these individuals is after COVID and how to follow it. We also want to, for lots of reasons, I want to look at immunological function and the outcomes of systemic inflammation. And then, there's also interest in looking at the sort of social consequences of what happens. So we want to create this clinic in partnership with the Traeger Institute, with our institute, as well as the Center for Predictive Medicine and U of L Health. We've had many discussions with let's say, the top-notch administrators and people, sort of movers and shakers in the university. There seems to be a general sort of enthusiasm for doing something like that, and to be able to create this entity. We just have to figure out how this will operate. We are initially trying to create two different clinics. One would be internal medicine clinic, and one would be in Traeger. So anybody under 50 can go there, and over 50 can come here. And that we would have sort of research staff at both these clinics, so that we would be able to consent people into the study, and then we would create a cohort that we could follow for sort of indefinite period of time. Maybe they need following for 40, 30 years, 40 years, we don't know. So, but actually, if we have a firm, good cohort that we see sort of in a frequent fashion, then that would be very useful. So, so that's what we are, where we are. I think that it would be important that we work together and be able to sort of launch this initiative, and then have support. We're trying to get support for this clinic, because many of the things that we want to do may not be indicated or supported by insurance, and so they may not be billable expenses. So we want to create a stream of support, both from local sources as well as federal sources. We're trying to write some significant grant proposals to be able to fund this sort of a clinic. So I'm going to stop here and take any questions. I do have to show you the slide of the people who are involved. There's lots of people involved. I know if you walk up to any of our testing centers today, tomorrow, the rest of the week, you'll see that it is a major operation. It takes a lot of people who are in it and who have participated. And it is a very sort of difficult and very expensive activity. It takes a lot of time and effort. We have to test the people in the site, take the samples to the lab, test them, and then get the results back, report to them within 24 hours to our participants. We create the databases to be able to do analysis later. We have to do the work upfront of printing, mailing 30,000 letters, and then 30,000 reminders, and 10,000 door-to-door flyers. So it's a sort of very extensive activity, but well worth it. And I hope that it will continue, and that we would be able to provide meaningful care to people in our community, and be able to contribute to whatever little we can in sort of assuaging the horrendous cost of COVID here. So I'll stop sharing, and I think we can have some discussion if you wish. I can answer any questions you might have.
Yeah. Thank you, Aruni. There's a few questions in the chat. I'm going to start at the top and ask the first one. From Joe, how do you determine where to take wastewater samples? How are you coordinating with national researchers, and are you finding similar results in other locations?
Right. So we are, the city sewage system is very old, from the 19th century. And so we had to work with this, with the sewage district, to be able to identify different watershed, waste watersheds. And so we have identified different places where we take the water, sample the water, wastewater. We're hoping that, and that we can tell us what the coverage is. So the distribution maps I was showing tells us what the coverage is of different parts of the city. So I think we have most of the city covered, in the sense that they are all represented in our sample set of 20 samples. And we have each of the population of each of the sewer sheds. So that's how we're sampling it, and we think we would have a good grasp of the geographic distribution of the sampling. We are also coordinating with the national samples. So the city also has a contract with BioBot. That's a company that is monitoring wastewater in 100 different cities around the country. And so we are sort of also partnership city with BioBot. So they give us the data on a weekly basis, and we compare our data to their data. The difference is that wastewater, that BioBot and other places just only sort of sample at the central treatment facility site. So they only have 2 samples for the whole city. But then we have that. We also do the same thing. So we have concurrent data, and our data are matching with those of BioBot. And then, but we also have more high resolution data in different parts of the city, so we can see where the infection is most. And I think we are going to talk later today with the city, showing them our latest results, where we identify hotspots where the infection is very high.
Thank you. Next question is, do you have any projections of how long-term the complications from COVID-19 may turn out to be?
Don't know. I mean, I wish we knew how long they would turn out. We do know that things like myocarditis, the level of inflammation that we have, doesn't easily go away for years. The type of things that I've seen CT scans of lungs, and I've seen MRIs of the heart and so on. They are not trivial changes. And from a past experience, let's say myocarditis patients or patients with some sort of lung injury show that the function really is compromised for a very long time. For instance, if you have cardiac fibrosis, it's very difficult to overcome. And same thing is, if you have some myocardial fibrosis due to inflammation, the function is permanently compromised.
Cool. How long do you think the COVID clinic will be in existence, especially if we get a vaccine?
Well, I don't think the vaccines will make any difference. We already have, several thousand people infected. We have to take care of these people. We have to follow them. And this should be a long-standing clinic that we could have a cohort. I mean, if we create one cohort of a few thousand people, we can follow them for many years. I mean, we have had these cohort studies in Framingham stuff going on for 30, 40, 50 years. So we can keep following these patients. That's why it's so critical to start now, to create a large, comprehensive, well-characterized cohort, so that in the end, if we follow that, we would be able to say something meaningful, rather than wait for reading the papers out of New York or San Francisco. That we would have our own data, that what our experience has been.
Yeah. Okay, next question. Are there medical protocols being established for patients that have long-term COVID symptoms?
Yes, so there has been some effort from the NIH. Again, it's really problematic that we are, let me admit somebody. I don't know how to admit this. I'm gonna, if you,
I did, you're fine.
Okay, great. So there have been this attempt to put together a team that would have a standardized national guidance of what should we be following. It's just that there is such lack of leadership in the federal government that there has been no directive. We're trying to do some grassroots things, 4 or 5 clinics, and you know, and people come together, they disappear. So I think if we have, I don't know, we few of us have to muster enough energy to put the team together, but there has been this idea has been floating around.
Yeah, okay. And then another question, are you thinking that people without symptoms who had COVID may also develop some of these long-term complications?
We don't know for a fact. I just know that one study in which they did CT scan of young COVID survivors who really did not have very severe symptoms, also had subclinical lung injury and fibrosis, that we suspect that they might have long-term issues. And that's the most sort of interesting population to watch. I was talking to the officials in NIH, and they said, well, every other place has all these people who come out of the ICUs and ventilators, and they're following them. What happens to them? Nobody knows how to follow asymptomatic patients because nobody has really found them, right, in large numbers. So we are the only city in the country that has done randomized sampling. So we have found all these asymptomatic people, and so we should be able to do this, and we seem to be better poised to do this and see if there are long-term complications or not.
Okay, next question from Erica. Are you finding any cases of people who are reinfected with COVID, or are COVID symptoms that reappear possibly still from the initial infection?
So we have not found any such case. Indeed, our immunological analysis, and we have not published this, so this is very preliminary, shows that there is not a very significant decline in the titer of the antibody. So the other unique advantage we have is that we have the Center for Predictive Medicine here, which has these BSL-3-4 facilities that are unique. There are only 12 such centers in the country. So we can actually do the titer of the antibody to see if they are neutralizing, which is a completely different thing than, you know, you get this kit that most people use. So we can see the strength of the antibody. And we can then also see, you know, long-term effects. So on long-term changes in the immune responses. And we've done it, and, you know, admittedly, our data is only 3-4 months, you know, but in the 4 months period, we haven't seen a very drastic decline in the strength of the antibody, right? So it's not that the immunology, the immune responses are dwindling in a large number of people. That's not what we found, which is good to know. You know, we want, at least until this vaccine comes along, people who've been infected, we want their immunity to remain strong.
Yeah, yeah. Okay, so from Colby, now that the Traeger Institute is developing its integrative medicine program, how do you envision applying integrated therapies to long COVID patients? I imagine it will be primarily focused on symptom management, immune support, and mental health support. My wife and I are the Traeger acupuncturists.
No, so I really do think—
Do you have any thoughts on that?
Yes, so I really do think that an integrated approach will be very helpful, because there are lots of mental issues. People are scared, frightened, and then every little thing that, you know, if you have COVID and then you have a little cough 1 month down the line, you think, oh my God, I've got permanent lung damage or whatever, right? So there is a lot of stress. And so we need to explore. And I think this may be the case where we develop a new paradigm of you know, patient care, in which we can address many aspects at the same time. I know people have talked about this for a long time, but we could provide a much more integrated care than we have done in the past.
Yeah, yeah. Thank you for that. That's what we try to do. So thank you, Colby, and it's great to have you on our team. Joe is asking, many skeptics are saying that people would have medical complications even without COVID-19, but now because of COVID-19, everything is being attributed to COVID. Do you think that people would be having medical problems anyway?
Right, so that's the reason for having a large clinic. So we have an inventory of symptoms, so we know which are genuine, frequent symptoms and which are spurious symptoms, right? So otherwise, if we just look at one case at a time, we won't be able to tell. But so if we generally see the cases are reported by a large number of people, it's like what we call like you have side effects of medicines when you have a clinical trial, and you have side effects, and so you want to see whether you have a genuine side effects or some people just because they were taking the drug feel like they have all these symptoms. So we need to distinguish real from phantom symptoms, and we need to be able to separate the spurious from the genuine ones. And in order to do that, we need to have experience. Our physicians need to be experienced in what sort of things are real, what is not. We need to be seeing a lot of people, and only then we can tell. There is accumulating literature, not very good, but accumulating literature saying that what's most likely to happen, and then we can follow up. And that's another advantage of having a research clinic. Follow up to see that if they have like coughing and wheezing, that do they have a sort of structural abnormalities that can account for that symptom. Because symptomology is already always a very loose science, right? So, but if we can attribute specific pathology to those symptoms, then we might be in a more sure footing and provide much more secure treatment than we just go by symptoms alone.
So I think this question is related to what you just said. You said for the people who are having post-COVID complications, are they being assessed to determine if they had pre-existing conditions that may have caused the problems rather than COVID?
Yeah, so most people who have severe hypertension patients with COVID do have pre-existing conditions, and they could flare up, which is, again, so this has been a big debate, I think somewhat misdirected, that if you have heart disease and you have COVID and it precipitates heart attacks, and did you die of COVID or die of heart attack? I think that's semantic nonsense. We need to worry about, because whatever the triggering event is the one that's critical. So if you had not had COVID, you might have survived for another 15 years, but now you have an early MI incident. So I think that's just sort of red herring, throws everything off trail, and we should not be distracted by that. We know that if you have COVID, which is the what we call the sort of penultimate cause, then that's what we're going to worry about, and that's what we're going to treat. And so that's the thing, that if we do this sort of analysis, we would be able to tell that if you suddenly have arrhythmias and you've had COVID, then maybe there's a link or maybe there is not. So this is not a trivial issue to address, and we need to do the work.
Erica is asking, how do you sign up to be a patient at the COVID clinic?
So I don't know, Anna, maybe you could answer that. How do we do that? So there is
yeah. I can answer it if you want to. You can call our clinic, and I'm asking Justin if he can put the phone number in there, and then you just ask to make an appointment at the COVID clinic.
Right. Also, I think we were talking about this last week. We might send out something in U of L Health, and maybe even send an email to general U of L employees that we have this clinic, and maybe this week or next week, and where to go. So I think in internal medicine, Bridget Hitpole is one who is sort of developing this clinic there, and then Anna and Christian in the trigger.
Yes. Okay. And the expected opening date, I want to say that Dr. Hitpole's clinic is going to focus on people with active COVID, and then we are going to focus on the post-COVID part. So the question is, what is the expected opening date of the COVID clinic at Traeger? And as far as I know, it's ready.
Right. So you would know that better. We don't want to make a big splash in the sense. We don't want to sort of get a community physicians to feel that we're trying to take patients away, and there was all these sensitivities. I know Norton has opened a post-COVID clinic, and they have their own worldview, and we have ours. So we don't want to appear to be competing in that sense, but at the same time, we need to make it known. So I think there will be, watch out, we'll have small announcements, not a big splash. And then maybe in a few weeks, we'll have something significant to say.
Yeah. And if you call our clinic and you want to talk to someone specific, just say that, and say you really want to just talk to someone who can give you more information on the COVID clinic. So there's the number 588-4330. I don't think that's the right number, Justin. Yeah, that's the wrong number. We will get you the right number. The next question is the lung damage similar to IPF?
Well, it could be. We don't know yet. I mean, it looks kind of similar, but it is what the sequel is going to be. Whether it's going to be different, whether it will resolve on its own or continue, we don't know. So we'll just have to wait to see.
Yeah. Next question is, would you recommend that we get tested for the antibody if we didn't have COVID?
Well, sure. If suddenly you have been invited, you got an invitation card from us, please do come. But even otherwise, you should. If you just look at our community site, that you could register and get so tested. Like I said, lots of people don't feel anything at all, that they've had any symptoms and still test positive. So there is no way of saying whether you've actually been exposed to the virus or not. You might have an exceptionally good immune system that kill the virus without any symptoms.
Okay. From Beverly, what do we tell patients when they have questions about insurance coverage if sent to the post-COVID clinic? Likely there will be a lot of tests performed.
Well, so again, some things are going to be covered with insurance. If you come to the clinic and you see a physician and you have lingering health issues, I'm sure that would become covered. But the type of things that we were talking about, like CT scans and low-dose CT, lung CTs, MRI, all this fancy stuff may not be covered because they may not be indicated, and that's why we need to have support the research. But in general checkup and in follow-up, and if there is indication, certainly the insurance will cover that. Yeah.
That's the plan is to start with the clinic by only doing tests that's covered by medical insurance.
That's right. That's our initial plan. Thank you, Lina.
Yeah. So the number is 588-4340 if you want to call that number and you want to talk to someone specifically about the COVID clinic. And then Beverly is asking where the clinic is located within Traeger. Well, it's going to be probably more a question of when. I believe it's on Fridays. We're going to have the provider there. And I'm now blanking if there's going to be another day too. Aruni, can you remember if it's going to be another day than Friday? Tom is also on. I wonder if Tom can remember.
I was thinking Wednesdays and Fridays.
Okay, that's possible. If Tom, if you have the information, you can share with everyone. That would be great. Okay, it's Mondays and Fridays. That's what I thought. Okay, thank you, Tom. So Mondays and Fridays, we will have the providers there at the clinic who will be doing the COVID clinic. Any more questions from anyone? I think we've worked through all of this amount of questions. You must felt like you were writing an exam, Aruni. It's a lot of questions.
That's right. No, I think it's
anything else that anyone? Yeah, thank you. And Joe is indicating that the clinic is located at 204 East Market Street, Suite A, and you go into the rear entrance and you can just enter from there. And free parking. He also said there will be smiling faces that will welcome you to the clinic.
But this is exciting.
Okay.
There's a lot of interest. There's a lot of interest in the group, and I think that we should be able to do something significant and meaningful, and come back here and report to all of you in maybe a year of what we have learned and what we have been able to do with our community, and so we promise to keep you updated of our progress.
Thank you. Well, this was a wonderful discussion, very active. Justin is asking that everyone who was on here just quickly click on that link in the chat, just so that we can get your email address. That would be lovely. And I want to thank Dr. Bhatnagar for spending an hour with us. We really appreciate your time. And it's lovely to have this relationship with you and working together with your institute. So thank you. And we will see you all in 2 weeks. I want to say the upcoming session is going to be about COVID-19 and wastewater with Dr. Rochelle Holm of the Co-Immunity Project. She's going to continue along the lines of what we talked today. So thanks, everyone. Have a wonderful day and a wonderful week.
Thank you. Bye-bye.